So basically this document, the guideline on dengue for diagnosis, treatment, prevention, and control, we are in the process of having the fourth edition of it. So we have had three editions over the past 50 years or so. I think the first one was in 1978, subsequent one was 1997, and then we had this red one, which was in 2010, and now we are in the fourth edition. And the chapters in the document includes epidemiology, the first one, burden of disease, the clinical management and delivery of clinical services, vector management and delivery of vector services, laboratory diagnostics, surveillance, emergency preparedness and response. And the last chapter was the new avenues. Now, on the right-hand side, you see where we are. We have completed most of the systematic reviews. We are just updating a few chapters. The systematic review is needed only for 3 chapters. The others are basic texts because there is really no need for review according to the guideline group. Next one, please. So moving on to the next slide. Basically, it just shows that in terms of diagnostics, dengue diagnostics, there is a huge need to accelerate its development. Previously, we used to do evaluation of rapid diagnostics with the help of TDR, but now that has been given out. We are not doing it anymore, but there is a need to accelerate development of diagnostics because we are now faced with multiple arboviruses. And so there are laboratories working on multiplex where we might be having good quality diagnostics which could detect 3 or 4 arboviral diseases. So this work is in progress. Next slide, please. So basically, this just shows you the last evaluation we did of some of the rapid tests, which have shown to be, especially for sensitivity and specificity, some of them have done quite well. WHO does not recommend any one of them, but we just share the results of our multi-center evaluation of these tests. And of course, we are not doing it regularly now, but I think very soon more tests will be evaluated since more agencies are getting interested in carrying this out. Next one, please. So the first major review is the clinical chapter, and this through a lot of questions at the reviewers, basically because we are today faced with multiple diseases. There are countries almost all over the globe facing dengue, chikungunya together, or dengue, chikungunya, and Zika together. So there were a lot of questions. And this clinical chapter review, the systematic review, is one of the largest systematic reviews we have ever done. Over 66,000 publications were reviewed for this. And we have looked at the clinical and laboratory findings, which are useful to differentiate patients with arboviral diseases, the warning signs, the criteria for hospitalization, oral dehydration, the intravenous hydration, and especially recommendations for hydration in chikungunya and Zika, the use of platelets, and of course, the 2 common drugs in use, paracetamol, most commonly used, are they useful? Is there a role for steroids? So many questions came up. Next one, please. So basically, this is just to give you an idea of what this whole guideline review is. So essentially, for all the warning signs, the clinical findings, IV fluid, oral fluid management, you can see the number of publications, each one exceeding somewhere between 6,000 to 8,000 publications. And all these meta-analyses have been done, and we are just summarizing the results. Next slide, please. So the same thing, basically it is symptom management, and of course, in terms of non-vector disease transmission, for example, dengue can be transmitted through blood transfusion. Zika has more problems because there is a sexual role there, and this makes it more complicated in the review process. So all these factors have been addressed in this comprehensive review, which is almost complete right now. And we are just waiting for the final proof read copy and translation. Next one, please. So the main finding is, as you may know, that in the clinical side of dengue, there are warning signs, which was introduced in 2009. WHO was criticized for many of these things because the study involved a large study funded by the European Union involving over all the continents and more than 10 hospitals. And these warning signs now has got high level of certainty. And so the abdominal pain, neurological symptoms, bleeding, fluid accumulation, dyspnea, hepatomegaly, thrombocytopenia, the liver enzyme elevation, hematocrit elevation, all these have been confirmed to be of high certainty in this systematic review. So this is a very good finding because this helps us to consolidate the warning signs more in our guideline. Next one. So moving on to vector control, which is the main part of our discussion today. I had told you on the first day that dengue vector control can be effective only when implemented in an expeditious, comprehensive, and sustained way. And I also mentioned that dengue lacks sustained tools, like unlike malaria, where you have insecticide-treated nets, indoor residual spraying, which can go for many months or even year, for more than 2 years for nets, in fact. But dengue doesn't have that sort of sustained tools. Now, dengue vector control strategies have not been evaluated for impact on human infection and disease. This is another weak point. And I highlighted that this is a problem because of lack of funding. Many of the studies just end with entomological findings. So there's a huge gap there. The lack of evidence for basis for applying helps to explain why the vector control programs have got limited success in many countries. So more new studies are really providing the most valuable evidence, and we are living in a period where we are seeing more and more of these studies. Next one. So this one I had projected earlier on the first day. So as I said, there are targeted indoor spraying with moderate evidence, lethal OV traps, outdoor residual spraying, all with limited evidence, indoor space spraying, again, limited evidence. And then insecticide treated curtains and window screens are proving to be showing some evidence, but it is still weak. And then there is outdoor space spraying, which I said is very weak and very, very limited in evidence. Next one. So as I told you in the first day also that one of the high quality evidence we have with after a randomized control is the community mobilized program, non-chemical approach, heavily based on source reduction, done in Nicaragua and Mexico, which was published in 2015. And this study is a classic because this is the first randomized control trial showing that dengue vector control has an impact on the disease. Next one. So basically from vector control point of view, the summary is basically more conventional vector control interventions have demonstrated some level of entomological efficacy, and programs should select locally appropriate interventions. And this is a strong recommendation. The approach for vector control in dengue should target both immatures and adults. And this is a very strong recommendation. And that's the only way we can control Aedes mosquitoes. The intervention must be comprehensive and sustained with high coverage to prevent and interrupt transmission. Again, a strong recommendation. The dengue program should integrate entomology and epidemiological data, and I will touch on that later. And support from local and national government, especially for policy development, management, and staffing is very important. And we have to bring in intersectoral collaboration. So this is not an evidence, it's a good practice statement. Next one. So vector control, as I said, we have to target both the immatures and the adults. Now, source reduction with active community support should be the mainstay for control of immatures. It's a conditional recommendation with moderate evidence. Application of chemical and biological larvicides to water source containers and other larval habitats can reduce immatures. Again, the same moderate level of evidence, but it's a strong recommendation. When targeting immatures, we need to have high coverage rate and frequent reapplication. So this is one challenge we are faced with because we do not have long-lasting slow release formulations yet, though they are coming into the market. We hope that will address some of the needs, but again, it has got moderate evidence. Next one. In terms of the adults, Basically, indoor residual spraying with a high coverage, and these are targeted spraying, has shown to be quite good. I mean, these are mainly coming from the past when we managed to eliminate Aedes in the whole of South America in the 60s and 70s in order to control yellow fever. And so this evidence is, though it's strong, we still need good study data for that. And many countries, including parts of Australia, Mexico, and other countries, are using this method. Use of insecticide-treated curtains, screens have shown to be effective. Again, conditional recommendation with low to moderate evidence. Sporadic space spraying has very low or moderate evidence, which is basically outdoor spraying. And in the event of an emergency, space spraying is recommended for a fixed period of time with a high coverage. But again, evidence is lacking. The only evidence we have for space spraying, which is slowly coming up, is indoor fogging. Personal protection measures are again like topical repellents. We don't have evidence for that, but it's a good practice statement. And we are also looking at how improvement in buildings or house constructions can bring about control of dengue and other vector-borne diseases. This is also a good practice statement. We don't have evidence on that yet. Next one. Moving on to the surveillance chapter, as I said in the beginning, we are talking of a comprehensive surveillance where we have a basic surveillance package. We need to enhance entomological surveillance and integrate it with the surveillance of clinical data. Environmental and social risks have to be integrated, and we are going more for integrated system. We have to monitor the spatial and temporal trends of the virus. Resource allocation has to be made for this. Evaluation of the program has to be done periodically. And as I said in the beginning, disease burden is very, very important. And every country should carry out a disease burden study to understand comprehensively the true burden of the disease and the social and economic impact. Next one, please. So please click 3 times, please. So basically there is a stakeholder engagement. There is training, laboratory support. Please click on. And we are focusing more on systematic and timely reporting, especially with outbreak diseases. Next one. And the analysis of data on time. So these are key packages of the surveillance. You have the stakeholder engagement, the training, the laboratory support, systematic and timely reporting, data analysis for situation awareness. So all the details are here, but we really need this to be an integrated system. Next one, please. Please move on. So basically, in order to enhance the surveillance package, we need more sentinel surveillance. It can be also capacity to monitor both entomology and trends at specific sites. In more detail, the virus serotype is very important, and also the syndromic surveillance, where we use additional tools to detect any changes in trends. So all these are packages which are basically enhancing our surveillance, and all these will be mentioned in the guideline. Next one, please. Next one. So to just summarize the surveillance part on entomology, we know that we need to determine the vector abundance as well as geographic distribution. As I said in the first session, the vectors are moving and we really are not tracking it perfectly. So if you really notice, in every country, all these vectors are not stagnant at all. They have moved from, for example, in the case of dengue vectors, they have moved from urban areas to rural areas, and they are continuing to move across boundaries. So we have instances like only last year in 2019, we detected dengue outbreak in Afghanistan, for that matter, the first one of its type. So basically, an additional country has become vulnerable to the disease. So from a handful of countries in the 1970s, today dengue is affecting over 129 countries. So this shows you the geographic distribution. We need to monitor vectors and evaluate the vector control program, as well as the insecticide susceptibility, the session which you attended already on how to evaluate resistance to insecticides for both these vectors, Aedes aegypti and albopictus, is essential. Next one, please. So essentially what the guideline is likely to recommend. Please enter one more time. is that we need both monitor the immatures, because we are used to the Breatho index, the container index, and house index. We need to monitor one of them. Don't monitor three. Just choose one of those indexes. And because they are not sensitive, they are not very sensitive for our evaluation of the program, or basically for disease transmission. So we are really looking at more sensitive adult indices. So there are some studies now emerging that adults, monitoring adults would give you better results. So the recommendation to countries would be to use one immature index and one adult index. At the same time, please carry out the geographic distribution study as well as insecticide resistance study. Next one. So the other parts we all know, because there are dengue is a complex disease. We have environmental and social surveillance components, the infrastructure, the environment, climate factors, the movement of people and goods all contribute to the transmission. So wherever you can factor these, it's useful. Next one. And we are looking at the type of surveillance, the strengths and weakness of active surveillance, regional surveillance, event-based surveillance, rumor surveillance, and research-focused surveillance. All these have been included in the guideline, but I just want to highlight the need for regional surveillance, because we have instances where countries are exchanging information confidentially on the movement of virus. This is very interesting because there are countries in the American region, there are countries in the Western Pacific and Southeast Asia, and in Singapore is coordinating one such network. So this information of regional surveillance is very, very useful, not only for arboviruses, but also for other viruses, if you can think of expanding it. But it is useful for countries to be prepared and to manage the disease in a better way. Next one. So the last section of the guideline will address the new avenues. What are we looking at in terms of dengue? In what is new? First one is improved diagnostics. There will be new surveillance traps. There are several early warning and alert response systems. We would be addressing that. Vector control is really at a very exciting stage because we are getting more evidence, and we will see evidences with confirmed evidence for Wolbachia coming through, spatial repellents, Wolbachia population with population suppression method, sterile insect techniques. All these are undergoing various levels of evaluation. So we are expecting good positive results. And lastly, of course, the vaccines. We have two more candidate vaccines going through phase 3. So all these are going to really come as a package in the next probably 2 to 3 years to make control and management of dengue more effective. Next one, please. I think that's the last one. Thank you very much.